ready? You got me running.
I am Meredith Hirsch, and this is Working Healthcare. If you're watching me on YouTube, you'll notice that I no longer look like a Smurf. That's because I changed podcast studios. Super excited about that. And with the change in podcast studios, I also thought I would switch it up a little bit and record my intro after my interview. So I just wanted to share a little bit of information about what's going on in this episode. And it's really relevant right now because we're still in a government shutdown. It is the longest government shutdown we've ever experienced in American history. And my guest today is Dr. Michael Burgess, who just left Congress in January. And he was a part of Texas's 26th congressional district for over 20 years. And we talk about everything about why he left OB-GYN to become a member of Congress, the political climate in Washington, and how we got to where we are. We're in the middle of Medicare open enrollment, and he talks about the history of how we got into Medicare, I like to call it disadvantage, but Medicare Advantage plans. We talk about doctors in Washington and the Doctors Caucus specifically, but Dr. Burgess has so many ideas to share. I actually don't speak a lot. He's the one telling all of these stories that I find super fascinating. So I hope you enjoy this episode just as much as I enjoyed interviewing Dr. Burgess. Please enjoy. Dr. Michael Burgess, welcome to Working Healthcare.
Meredith, thanks for having me on. I appreciate it.
I am so excited to have you. I wore my red, white, and blue outfit today in preparation for this. And you are actually my first congressman on Working Healthcare. I've had state legislators, but I've never had a congressman. This is exciting to me because you're also a doctor. I want to get into the craziness that has happened in the past 24 hours and specifically in the past 35 days. But you're an obstetrician by training. Why did you choose to leave medicine and go the political route?
Okay, well, first, as of January 3rd of this year, I am no longer in the United States House of Representatives. I am a former member of Congress, so I do need to point that out. I can't vote for any of the stuff that you're seeing right now. My journey to leave the labor and delivery suite for the congressional offices really began the day of 9/11. It was a pretty scary day, a pretty tough day.
You went into the House of Representatives, or you ran for office after 9/11. What was it from 9/11 that triggered you to want to get more involved?
Well, it was very disruptive. In the weeks and months that followed, I began questioning. My son was in the Air Force, so he's obviously serving his country. And I began to question, my country was attacked. Am I doing everything I could be and should be doing with my life to help my country? I made a pact with myself that if an opportunity arose, I would not shy away from it. I would embrace it. What I didn't expect was that my member of Congress, who'd been there a long time, but my member of Congress announced in early December of that year, December of 2001, that he would not seek re-election. Texas has a very early primary, so our filing period then was essentially the month of December. He announced about halfway, I think it was on December 12th to be precise, and I had to decide before January 3rd whether or not I would file for that now open seat in Congress. And I was the last person on the last day to file for election in that primary.
How did you raise money? How did you even get involved in this world? Because right now it's all about raising money. You're a doctor, and then you pivoted into politics. So where did you even start?
Well, first off, everyone assumed because I was a doctor, I was extremely wealthy, but that is not. Let me disabuse everyone of that notion. I did get a recommendation for a consultant whom I hired, and he told me to put $250,000 of my own money into the campaign or people wouldn't think I was serious. And I said, well, what is your retainer for these 3 months? And he said, $30,000. I said, I'll put $30,000 in, and then you help me raise the $250,000. He actually did not meet his side of the bargain. I may have had one of the least expensive congressional victories. I had an opponent who was able to raise phenomenal amounts of money. I did have help from Doctors in Texas Medical Association, who were a little cool to the idea at first, but then warmed to it as the campaign progressed. They did a fundraiser for me probably in February. That's really what put a lot of the gas in the tank that I used to get through the primary. At that time in Texas, you have to get 50% plus one in order to advance. No one got 50%, but I was in the top two. And 4 weeks later, there was a runoff that was one of the most intense periods of my life. Almost unbelievable how intense it was. The consultant I had said, we're going to raise some money and spend it from election day backwards. An open congressional race. There were six people who were competing, one of whom was the son of the then current member of Congress. So it seemed to everyone who looked at it, well, that's a given. This guy is, as romantic as it is, an everyman physician running for Congress can't do it. But we did. We got into the runoff, and then I was successful in making the case. But I will tell you, it was an incredibly intense period of time. Congressional terms are 2 years. And you hear a lot of people talk about, well, I'm going to start in that, early in that 2-year cycle and make a name for myself and run for an office. But you've got to, in fact, the runway has to be longer than 2 years. I did not do it the right way. I just sort of jumped into it. I didn't know what I was doing. I had some good advice along the way. And what I didn't appreciate was how big a constituency I already had. There was a 4-week runoff. During those 4 weeks, I can't tell you the number of people who came up to me and said, I keep seeing your name on yard signs, but that's not you, right? You wouldn't be stupid enough to do that. And yeah, that is me. And that actually accrued to my benefit, where people were able to figure out, hey, that fellow I've known for a long time and have trusted my healthcare, trusted with my family's healthcare. He's asking to be my congressman now. I think I'll trust him to do that. So that was an enormous amount of equity that I did not know I possessed when I got into it.
I love that underdog story. That is so inspiring. My husband does have a desire to get more involved on the political side, but times have shifted even back from 2002 when you started running. Look, yesterday, Zohran Mamdani won New York. It baffles me, but he also had so much of the young vote. Do you see that has shifted in the 20 plus years that you initially ran? Social media is so vital.
Well, I'll tell you who the real winner last night was. The real winners were Florida, Texas, and Tennessee. The giant sucking sound you're going to hear are people fleeing the citadel of New York, and they're going to be looking for freedom, and they'll look for it where? They probably won't look in California. They're probably not going to look in Oregon, but they're going to look in Florida. They're going to look in Texas. They're going to look in Tennessee, places where they know there's a good chance of live without the interference of an overbearing socialist.
Exactly. And our governor is actually trying to figure out how to make property taxes zero for everyone who actually owns properties. So you're going from New York City to, hey, if I change my residence to Florida and buy a property. So Zohran Mamdani is now the #1 realtor in Florida. What about Texas?
I'm sure. Of course, since we're closer to California than you all are, we were already the recipient of a great number of Californians who left, as a kid. You think, oh, California's the Golden State and everyone wants to move there. Not so much anymore. People are looking for an exit ramp. They found the free state of Texas, and in your case, the free state of Florida. Many New Yorkers are probably already familiar with the free state of Florida because they have a second home there. And they may just be switching their residence, as our president did, moving from New York to Florida. It's not it's a time-tested strategy.
It definitely is. And with that race, we also are in the longest, as of today, government shutdown. And the big discussion right now is about Affordable Care Act subsidies. While you did not run for another term, and I definitely want to talk about why, you were in Congress for over 20 years, and you actually co-chaired the Doctors Caucus. I'd love to hear from you and your perspective about why we're in a shutdown. What is really the debate between the Democrats and the Republicans? Now, I hope by the time this podcast episode airs, which will be in 6 days, we're no longer in a shutdown. But as of today, which is Wednesday, November 5th, we are now in the longest government shutdown. So what is the real reason behind this shutdown?
Well, Chuck Schumer is the reason behind the shutdown. When he voted for a continuing resolution last March, he got clobbered by his base, and he's scared witless about Alexandria Ocasio-Cortez, who could very well challenge him for the Senate. And I think after last night, seeing Mondami's win, she's probably chomping at the bit to file for his Senate seat. That's the main reason. Chuck Schumer was at the end of his political rope, and he was looking for a lifeline. And the way to do that was, hey, show we're tough, we're strong, we can stand up to Trump and Mike Johnson and Leader Thune, and will not acquiesce to this government funding, which is the same funding that President Biden asked for time after time after time again, that every Democrat in the Senate voted for time after time after time again. And bear in mind, it was this funding bill that passed the House at the end of the fiscal year in 2003, so September 30th of 2003. And it passed just by the skin of its teeth in the House because most Republicans did not want to spend to the levels that President Biden wanted. We were spending to COVID subsidy levels. And the next thing that happened was Kevin McCarthy got tossed out as Speaker about a week later because of that funding bill that he got passed through a Republican House. Many of the Republicans thought, to great umbrage, that we're spending so much money and it's every dollar that Biden ever wanted, and it's numbers that were increased because of the COVID-era subsidies, and we've had enough of it and we're taking out our Speaker. First time that's ever happened in the history of our country. And now the same funding levels, Chuck Schumer says, it's just not acceptable. They're saying, in exchange for 6 or 7 weeks of funding the federal government, we want to add $1.5 trillion to the national debt in order to do that. Well, that's clearly just a non-starter. If people looked at that rationally, they would say Chuck Schumer is not of his right mind. He's the reason why this government remains shut down. Now, let me give you another perspective. In 2013, Republicans had just taken over the House of Representatives. We were back in the majority after a couple of terms in the minority. Obamacare was passed and signed into law. It was about to go into effect the early part of 2014, and Republicans in the House said, we don't want that to happen. It is so bad. We are willing to withhold funding from everything so that they'll rethink Obamacare. President Obama was never going to sign a bill that undid what he considered his signature achievement in his first term. And as a consequence, it was never going to, Republicans in the Senate, not Republicans, Democrats controlled the Senate. Harry Reid controlled the Senate. John Boehner and Republicans controlled the House. We had a pretty comfortable majority of the House at that point. But Republicans in the House said, we're not funding the government because we think Obamacare is such a travesty. Turns out we were right. We think Obamacare is such a travesty that we don't want it to happen to the American people. And so the government shut down for, I think, 23 or 25 days, looked upon as just an apathy that Republicans would do this to the country. As a Republican who participated in a government, let's call it an appropriations lapse rather than a shutdown, you don't realize how many air traffic controllers are your constituents until you stop paying them and require them to go to work. It is frightening for that segment of the population, not just air traffic controllers, TSA agents. I don't have the DFW airport in my congressional district, but I do have a lot of families that work there and whose income depends upon an airport-related job. They are air traffic controllers. They are TSA agents. And even the pilots themselves, although their pay was not affected, their ability to do their job was affected by the shutdown. You heard about it from your constituents. They were livid that Republicans would do this to them. So now kind of the shoe's on the other foot, except that Republicans, for whatever reason, always have the blame for the shutdown. But here's the critical thing to remember about a government shutdown or an appropriations lapse. In the end, no one wins. It is not a strategy that anyone should pursue. And it is really wrong right now for the Senate to be holding up the funding for the government. But when it happened in 2013, we were told by Harry Reid we'd send over bills to fund the military, to fund the NIH, any number of things where you'd think these are good government things that people would be. No one in the Senate could vote against this. Oh, yeah, they can. And they would say, we're not even talking to you until you open the government. And that's kind of the position that Leader Thune has taken now. But unfortunately, unlike Harry Reid, who was regarded as a hero then, Leader Thune has not. He's been more criticized than he has held up for adulation because of the way he's held the line in the Senate. But look, here's a bright spot, and I think that you're right. Before 6 days have gone by, the appropriations bill will pass. They will probably extend it to longer than November 21st.
That's what I was just thinking. November 21st, we have to vote again because in 2019, we had a 35-day shutdown that ended after the year. And I know medical practices were really struggling. Ours did because the updates and changes to the Medicare physician fee schedule were delayed. It was a massacre on the revenue cycle management side for medical practices.
Oh, absolutely. And even going a little further back for the Deficit Reduction Act of 2005, the same thing happened. The Senate didn't pass the bill until late in January that year, but all the positive adjustments we were able to get in the Medicare fee schedule for physicians were held up that month. Docs had to refile their bills after the end of January when the bill finally passed. We're talking about bills that might just be a couple of dollars more expensive to resubmit the bill.
Oh, 100%. 100%. A lot of our contracts, I know with United Health Group, my contract with United Healthcare stated that they required 60 days to update their fee schedule after CMS updated their fee schedule. Our reimbursement was never retroactivated from UHC. It was pushed back 60 days after Congress reopened the government. What was it, January 19th, 2019? It's insane. And you're right. I think we spent more money resubmitting and trying to figure out the differential between what we were paid and what we should have been paid because we were required to resubmit. What do you think the Democrats are saying on their side regarding the CA subsidies? Because you can listen to CNN and hear one side, you can go on to Fox News and hear another side. So Chuck Schumer must have a reason as to why they can't vote to reopen the government. What's their perspective?
Oh, I would not attribute strategy to any part of the thinking of the Senate Democratic leadership right now. But what I will tell you is that this election last night, I mean, the Democrats, rightly so, are going to say, hey, we went up and down the scale. And yes, it was blue states and blue cities that they won. They won stuff they were supposed to win.
Exactly.
And it would have been a headline had they not won one of those races. But they won what they were supposed to win. So now a victory will be claimed. Chuck Schumer will say, we held out for you, the American people, and you rewarded us with a resounding victory in races we were supposed to win anyway. But we got this resounding victory. So they can take a victory lap and then an off-ramp. And that, I think, I mean, I don't know, I'm not there anymore, but I would think that would be the strategy. You will hear over the next several days, Democrats declare victory on the shutdown, Republicans caved, and we won all the elections, so then they've got to give in. Remember this, the subsidy stuff that we're talking about were the enhanced advanced premium tax credits. These were passed in 2001 in the American Rescue Plan and then in the Deficit Reduction Act or whatever the hell they called it, Inflation Reduction Act
right.
in 2002. In response to COVID, we've got to plus up the subsidy window a little bit. Trust me, we did not repeal the Affordable Care Act. So the advanced premium tax credits that were part of the Affordable Care Act have not been repealed. So they are still, they will be in existence. They have been in existence. They'll be in existence this month and next month. So anyone who places their average yearly earnings at between 100 and 400% of the federal poverty level is still going to get the Silver Plan level subsidy that they were getting all the time in the Affordable Care Act. What changed with the American Rescue Plan was they said 400% of poverty is not enough. We want to go way up. So individuals earning $250,000 a year, families earning $500,000 a year, were eligible for subsidies. The reason that the Democrats voted for that in the first place, it was only 2 years in the American Rescue Plan, and it had an end date of this December in the Inflation Reduction Act. Why didn't they just do that in perpetuity when they held all the levers of government? The reason they didn't was because the Congressional Budget Office score on that was going to be hundreds of billions of dollars, and they couldn't face it. So now they're saying, well, Republicans should do the right thing and just make these subsidies indefinite. Maybe that is the right answer, but if it were the right answer, why didn't the Democrats do it in August of 2002 when they passed the Inflation Reduction Act that extended these subsidies? But then, the answer to all of this is, the great thing about socialism, you eventually run out of other people's money. They were going to run out of other people's money, and they didn't want that to happen on their watch. They wanted it to happen on Republicans' watch. And then guess what's the next statement in this story? They're going to clamor for massive tax increases. You've already heard that, where they say that the Republicans are just for tax cuts for billionaires. That's not true. Everyone's taxes got cut in the Tax Cut and Jobs Act of 2017. The tax code was simplified. Then Biden did his best to raise those taxes and make the code more complicated again. But that's the next act here. They're going to want to raise taxes. Yeah, they're going to say on the wealthiest, but you and I know this, Meredith, wealthy don't pay taxes.
Exactly.
They don't get a W-2 that says $1 billion on it.
The Wall Street Journal calls them high-income earners not yet rich, Henrys.
Yeah. Okay.
They're the ones who pay the high taxes.
Yes. And this is where people get misled by this. It's great. We're going to get some free stuff. Other people are going to pay for it, and everything will be great. What I do see, and I've actually talked to people about this before I left, I said, the day's going to come where these enhanced tax credits expire. We ought to prepare for what is next. No Republican wants to own any part of the Affordable Care Act, and particularly the enhanced advanced premium tax credits. But you do see some people talking about it now because they have family members and constituents who are going to be affected. The right thing to do would have been to look at, when they passed Obamacare, up to 400% of the federal poverty level, you got a pretty generous subsidy to buy insurance at the silver level in Obamacare. Mm-hmm. And in fact, pretty much zero premium for some policies. But once you got to 400% of the federal poverty level, boom, your subsidy is gone. So you're immediately paying the full freight of these now very expensive insurance policies that Obamacare has created. In my district, it was a teacher and a policeman with 2 kids earned just above 400% of the federal poverty level. So immediately they got hit with a massive insurance premium that they could not afford. I'd have people come into the office all the time. And of course, at that point, you had the individual mandate. Say, oh my God, the government's requiring me to buy this stuff. No way in the world I can afford it. I can't afford this in a house payment. What am I going to do? Well, the right thing to do is let's look at why insurance has become so expensive. Maybe there's a way to make a lower cost option available to people, or maybe you could gradually phase out where the 400% of poverty level, where that increase suddenly occurs. Like in Medicare, there's income relating to the Part B premium. At the lower levels, it's one thing. At middle levels, it's another thing. Higher levels, it's even more. Most people think Medicare is free, but when you end up on Medicare, you find out there's a substantial premium deducted from your Social Security checks. Most people aren't aware of just how much they're spending for their Medicare, but income relating to Part B premium did make it more expensive for seniors who earned more or had greater assessments on their wealth, it made it more expensive for them to be on Medicare. But that's part of the deal. They should have done something like that with these enhanced subsidies in the Affordable Care Act. It was wrong for Obamacare to set it up so that when you earned $1 over 400% of the federal poverty level, suddenly you're hit with these massive insurance costs. And guess what? You've got a deductible that still means you're functionally uninsured. You get a kidney stone and go to the emergency room at 2:00 in the morning, you're getting a $4,000 or $5,000 bill because your deductible is $6,800.
Right.
I know this because I had a bronze plan on Obamacare after it passed in 2014. You are functionally uninsured. You've got to keep a healthy cash amount available to cover medical expenses if there is an emergency, because beyond that, you're not covered.
Well, I call it catastrophic care. If you cannot afford health insurance and you qualify for an Obamacare plan, go on to it. Hospitals will cover you. Our practice doesn't cover any ACA plans, and at least it's catastrophic care. God forbid you end up in the hospital. Otherwise, there's so many opportunities to do a fee for service or do a direct pay model in healthcare, especially in Florida, and I know there is in Texas. And you can then pay cash for your E&M visit. You can pay cash for, if you really can't afford it, there are pharmaceutical companies who will help you with government assistance programs, or rather pharmaceutical assistance programs. And there are opportunities for so many charitable programs if you truly cannot afford your medication. So there are ways to go about it. And you're right, the ACA plans are really just catastrophic care. I'd love to talk to you about those premiums that you said. And this has to do with the government shutdown. And I'm hearing so much, and just got actually not an actual quote from our health insurance company for our company's health insurance for our practice. We have a renewal March 1st. I was looking at moving it up January 1st because that's when deductibles and copays restart, and it's so much easier. I have a feeling we're going to actually have to change insurance companies for our practice coming in March. So I just thought it would be easier, but I'm getting a quote of about 17% more than it was last year. But I've heard people who are not part of ERISA plans or not part of their employer plans that are getting quotes that are 5 times the amount that they're currently paying. Does this have anything to do with the government shutdown? And do you see this easing up when 2026 actually hits?
I don't know that it has much to do with the government shutdown, but it is a problem. Who benefits from the subsidies? That subsidy doesn't go to the patient. They say, here's your money, go buy the best, go to the market and buy the best policy you can. That would be one approach that people might consider. But instead, it's a direct payment to insurance companies. Mm-hmm. So they're laughing all the way to the bank. And let's be honest, they really don't seem to have any moral quandary about raising the rates so high that people can't afford it anymore. It doesn't seem to affect them. So that's one of the dangerous things about when you encourage people to absorb massive amounts of federal money, they don't give it up easily. And that's what you're finding with the insurance companies right now. They have gotten used to these vast amounts of payments that they're getting in the subsidy payments. That translates to higher payments for people who are in non-subsidized plans. I had a small practice, so we bought our health insurance in the small group market. And that, you're right, they can be particularly hard hit when these types of changes come along. Now, I'll tell you one of the brilliant things that President Trump did in his first administration. We've talked about what's called an association health plan type arrangement for some time. It's never been able to pass Congress. Insurance companies hate it, hospitals hate it. But an association health plan for your small physician office, think of barbers and beauticians, real estate agents, chambers of commerce, small employers would be able to group together and buy in the large group market. That does a number of things. They get the buying clout of that large group market, which kind of holds down their premiums. And then there's another thing. In the ERISA plans, and everyone forgot this in 2018 when the hue and cry was pre-existing conditions. ERISA plans, if you get through the probationary period of your large group employer, you are covered through health insurance and retirement plans. So whatever the probationary period is, 60, 90 days, and there is no exclusion for pre-existing conditions in the ERISA health insurance market. Newt Gingrich and Bill Clinton in 1996 made an agreement. Part of the agreement was in exchange for being able to sell these multi-state plans, the coverage would begin as soon as a person got through the probationary period. Now, you still got to get through a probationary period. If you're in your probationary period and they find out you robbed a bank in another life and they fire you, you may lose your benefits. But for most people, that's not a problem. They get through their probationary period and they have coverage. It doesn't matter what diagnosis they had last year, they are covered. You think about what Obama said, okay, I want to do away with pre-existing conditions. Well, here's the roadmap for how to do that. Let's expand the ERISA market. Not that it's perfect. There are problems in the ERISA market. Let's expand those types of market protections to smaller businesses and allow something like association health plans. Trump did it as an executive order, immediately got sued, and it's been held up in the courts. But really, if Congress wanted to do something meaningful, that would be the way to do it. Association health plans, health reimbursement arrangements. These are ways that you put patients, employers back in the driver's seat, and you're not so beholden to insurance companies. Rather than saying, let's give people a break on the price of their health insurance and we'll pump federal dollars into it so their price isn't so high. Guess what? The cost is still high. Someone is paying that cost somewhere. And in a non-ERISA plan, they are going to pay that increased cost because the insurance company is passing those costs onto them. This argument would be much simpler if people understood the difference between price and cost, but they don't. And of course, the Democrats on the politicians' side are willing to make political hay out of this. I think that the worst thing that could happen is that the Republicans would agree to a one-year extension on the enhanced ACA subsidy premiums. A couple of reasons. Number one is that'll put you right up on the threshold of the midterm elections a year from now. Don't do it. It's a trap. The bottom's going to fall out from under you and you'll be in the Malayan man trap. If nothing else, do it for 18 months so that you're in a different part of the cycle. Like you said, let's find a way so that people get a direct primary care option going to be available for these people with the advanced premium tax credit? No, because the insurance company's profiting from it. So there's no impetus driving market improvement in those types of plans. I had a health savings account back when I was in practice. 1996, the Kennedy-Kassebaum Act passed. Again, a compromise between Newt Gingrich and Bill Clinton back in the day. A true health savings account or medical savings account, as they were called then, you were able to put a certain number of dollars away into a tax-deferred account, just like your IRA. People used to call them medical IRAs. And then you carried a high deductible plan, which is less cost to you in premiums. Times you would have to depend upon the money you'd saved in your medical IRA. But the good news was, if you got to the end of the year and you hadn't had to spend it, it was yours. It's not an FSA where it goes away at the end of the year. It's yours. It stays in your bank account. And I'll never forget Mitch Daniels, who was President Bush's head of Office of Management of the Budget, went on to become governor of Indiana.
Two of my boys went to Purdue. So Mitch Daniels was also president of Purdue. So love that. You want people who have skin in the game. And I love that you said that because I have a friend, remember this story, he shared it with me several years ago. He's a doctor in Oklahoma and he used to see a lot of indigent patients, but instead of doing it for $0, he wanted to have an investment from the patient, and he required $5. That was it, $5. He didn't bill insurance. These people didn't qualify for whether they were on Medicaid, and he wasn't contracted with Medicaid. I don't recall the story, but he said, you're going to make a different decision and you're going to be more vested in the decision that you make if you're shelling out something and it's not 100% free. So I 100% agree with you. I have an HSA plan to this day, and I constantly think, I'm not going to the hospital to get this done. I'd rather go to the standalone clinic.
Yeah, absolutely. Unfortunately, HSAs are not available in Medicare. I wish they were. I think one of the improvements, if Dr. Oz and RFK Jr. want to make an improvement in Medicare spending, allow Medicare HSAs to become a true thing. I'm on Medicare Advantage, and a couple of reasons for that. Number one, I voted for it. I voted for it in 2003. Like everyone else, I like the concept of one-stop shopping. I get one policy. It covers my Medicare, my Part B, my Part D prescription drugs. But at the same time, there's things you give up. The darn prior authorization part of Medicare Advantage has become particularly onerous. Watch out, people. It's about to get even more onerous if you're on standalone or traditional Medicare. CMS is instituting a model in some states. My state of Texas is one where they are going to have prior authorization required for standard Medicare, for traditional Medicare, which in the past has not existed. CMMI was another part of Obamacare, which never should have passed. People will say, look, if we don't like what CMS is doing, we'll just cut their funding in the next appropriations bill. Well, we're not doing appropriations bills is one argument, but the other is CMMI was pre-funded in Obamacare.
What is CMMI?
Center for Medicare Innovation.
Thank you. Yes.
As the Innovation Center in Medicare, it's a big government control mechanism that Obama wanted. I tried to repeal it a couple of times, and then the CBO said, oh, you can't repeal it because it saves so much money. Finally, last year, I got a hearing in the Budget Committee where the head of the Congressional Budget Office had to come in and admit CMMI saved no money. It spends a ton of money. It's not saving anybody a dime. But here's the other thing. You give up a lot of control because Congress doesn't get a say in these models that the Innovation Center then puts out. So the one now is called the WISER model, and it will be a way for prior authorization to exist in traditional Medicare. And then here's the rub. If your doc say, look, you got traditional Medicare, I had this procedure done. Now Medicare says, well, that's a low value procedure. They will claw back the amount of money that they paid you for it. They don't expect you to write a check to them. They'll just take it out of your next check that you are going to get from Medicare. This is a terrible program, and it really pains me that it's a Republican administration that is using a Democrat agency trick to foist this onto the American people. As a Medicare Advantage patient, I've recognized that prior authorization has been an anathema in Medicare Advantage. Healthcare has been one of the worst, if I can name it. You'll get a call in the middle of the afternoon when you weren't expecting it and say, hey, we just reviewed your doc put in for this or that medication, and we just reviewed it. Our care team reviewed it and has said it's not medically necessary and we're not covering that. I've gotten those calls. And my response is always, first was, where are you calling me from? It turned out it was from the Philippines. Well, okay, let's go a little bit further. Is there a doctor on your care team? Oh, of course, we've got doctors and pharmacists and nurses. Is there a doctor that I could talk to? Because if there's a doctor and they're not licensed in the state of Texas, they're practicing medicine in my state without a license, and I think the Texas Medical Board will be interested. So can I have the name of that doctor? They hung up. The next thing I knew, I got a letter saying that was approved. No sweat. We so sorry to have troubled you. But most patients don't know.
They don't know that. And they can be on medication for 20 years and stable. And then the insurance company comes in and denies the prior authorization. I know that in 2003, it was the Bush administration that passed Medicare Part C, and it was what we all call Medicare Advantage. I personally call it Medicare Disadvantage. I am baffled that you're still on an MA plan. What about Congress? Are most Congress people, do they choose MA plans, or they're smart enough to stay? You're smart, but is it that you can't go back onto Medicare, traditional Medicare?
Well, I could, but then you've got to got to get a supplemental policy. You've got to get a separate drug policy. Things are stable right now and working. I mean, there's some aggravations, but there's always going to be aggravations when you put insurance into the mix. So I'm willing to accept those aggravations. If I could switch to a Medicare Advantage that was a health savings account, I'd do it in a heartbeat. And look, here's the deal. Medicare Advantage plans are greatly subsidized by the federal government because there was a fear when MA was created, there was a fear that no one will show up to sell these policies. So we've got to provide this inducement. I remember Chairman Bill Thomas of the Ways and Means Committee said it's just going to be temporary, but we've got to allow them a reason to participate. If you took that generous subsidy, which is still occurring, by the way, if you took a portion of that generous subsidy, you don't have to take it all away from the insurance company, but say, look, we'll split it with you, say 70-30, and the patient gets 30% of that to put into an HSA. Suddenly, you're going to have an activated consumer. You're going to have a consumer-oriented health plan in Medicare, and that would be extremely powerful, rather than the agency telling you, we deem this to be low-value care, and so we're going to ding your doc who ordered it or provided it for you. Let's put the patient at the front end and say the dollars are in the patient's hand and the patient will make a decision. Same thing about 340B. I mean, the 340B, the abuses in what was designed as here's how we're going to help low-income people afford some of these expensive prescription drugs. And I got to be careful here. Parkland Hospital was not in my congressional district, but I did my residency there. And the CEO knew my phone number. Anytime I would rattle the cage about 340B programs, he'd say, look, that's the only reason we can provide care to patients. And you're right, Fred, that is exactly right. You do it right. You should be able to continue that. But when President Obama made 340B plans available to commercial pharmacies, and then CMS and Aetna merged, guess what? The 340B plan is making everybody rich, but it's not helping the people that it intended to help. Talk to any of your oncologists who have had all of the small practices absorbed by hospitals now because they get those 340B payments to flow through them, and it is a profit center rather than a way to help patients who are having difficulty affording their prescription coverage. It's a profit center for private equity, big hospitals, nonprofit hospitals. Forgive me for saying this, but some days they don't feel like nonprofits anymore. It seems like they're in the business of the bottom line, which is sometimes it's hard to tell the difference between a Methodist hospital and an HCA hospital.
So let's talk about that vertical integration. So when CVS and Aetna merged, right, you have the PBM and the pharmacy and the insurance company, and now they're purchasing all of these medical practices, right? You talked about private equity. Well, oh my goodness, this has been a crazy year, 2025, in the purchasing of independent medical practices. You even have Cardinal Health now, which is a specialty pharmacy purchasing medical practices. And you said it yourself. This is why oncologists are now part of the hospital sector. It's because there's so much profitability in their infusion suite with their medication. And we're seeing this on the rheumatology side. I just left a meeting before I came here for our interview with Cardinal Health, and quarter over quarter, the spread of our medication continues to decrease, and we are underwater for 3 of our infusible drugs. We don't even make enough on the admin code because, of course, there's been no increase in the physician fee schedule since 2000, but we don't make enough on the admin code that these rheumatology practices are surviving because of the spread in the medication. And if you screw that up, you're bankrupt and you're going to wait for someone to just take you over and get you out of bankruptcy. What are we doing about the vertical integration? What is Congress doing? What are your thoughts? What's the thoughts of the Doctors Caucus to create change in this vertical integration so we still have independent medicine? We still have care for patients. I know that's a loaded question, but you've said so many interesting pieces of information. You shared so many interesting pieces of information. I'd love to know your thoughts on that.
One of the worst things in the Affordable Care Act, after you got through the individual mandate and the Innovation Center at CMS, was the prohibition on physician-owned hospitals that went into effect actually a week after the president signed the Affordable Care Act into law. And I know this because I had to go to bat for one of my local hospitals. It was a physician-owned hospital that opened 2 weeks after the bill was signed into law, and CMS was going to disallow them from being able to do business. Well, this prohibition on physician-owned hospitals, number one, it's anti-American. It needs to end. Why should I, just because of my advanced degree, be prohibited from engaging in a business practice? Mm-hmm. You would not prohibit a nurse from owning a hospital. You would not prohibit a lawyer from owning a hospital. Why is a doctor prohibited from owning a hospital? And why is it important for a doctor to own a hospital? Because we understand we're cost-conscious consumers. We approach things with the knowledge that, yeah, I may like this fancy argon laser, but I know an old-fashioned cautery unit can do the same thing. So I'm not going to undertake that large expenditure. Physician-owned hospitals would be a way. And look, we've had a lot of tears being shed over rural hospitals, and Republicans are going to hurt rural hospitals, and the Democrats are going to take away the $50 billion rural hospital fund that was in the big, beautiful bill. What if you let doctors invest in hospitals in medically underserved areas? I had a bill that did exactly that. It got blocked by a number of special interests. It's still out there, and people are still moving around the edges. I think Morgan Griffith from Virginia has picked it up now. But if you allowed, if you had a group of physicians who said, look, we just think it's a tragedy that there is not a hospital, there is nowhere to get a surgery or a baby delivered in a 50 or 100 mile radius, and we would like to put our dollar on the line and build a hospital or run a hospital in this medically underserved area, why don't we let them do that? Well, the reason we don't is because Obamacare said, and this was all Pete Stark from California. Most people now don't remember who he is or was.
The Stark Laws.
The Stark Laws, which is one of the darkest days of medicine in 1981 when they started with that. Look, I'm a Republican. I really dislike Eric Swalwell for a number of reasons. But I will admit, he was the one that defeated Pete Stark in a primary. So for that, doctors ought to hold him in high regard. So he's the reason we got rid of Pete Stark. Now, he's been miserable ever since then, and there's all kinds of reasons that he shouldn't still be in Congress. But the Stark Laws and the prohibition of physician-owned hospitals was Pete Stark's baby when the Obamacare bill passed out of the House and Senate in 2010. If you allow doctors to be the owners of hospitals, you could have specialty hospitals, say even a rheumatology group or an oncology group or a group of OB doctors, but you could have general hospitals as well, where the hospital was run by doctors, financial decisions are being made by doctors, and the accountability to patients. I mean, doctors, we understand accountability to the patient. We are in the final analysis, we are the advocate for the patient. Some days we're the only advocate the patient has left. So why not let us be in charge of our own hospitals? I will tell you this. I mean, I did a surgery center right before I ran for Congress with another group of doctors. I was criticized when running for Congress. People say, oh, this is just a way to cherry pick only the best insured patients. Look, as a doctor, what's the most valuable thing to me? It's my time. Mm-hmm. And if I've got a raft of minor procedures that I'm doing in some morning, and I add on a Medicaid patient to the end of that, that's not a problem. I'm there anyway. The turnover time between rooms is minimal. If I take that patient and say, well, you've got Medicaid, so I'm sending you to the hospital, then I'm in line behind all of the other cases. And if it's late in the day on a Friday afternoon, I got bumped for an appendix in the emergency room, and that patient may not get their operation that day. They may have to wait until next week, even though they've taken time off work, arranged for childcare. It was a big problem when all I had for an option was a hospital operating room. When I had an outpatient surgery center as an option, it opened up a whole new world for me. And then here's the other thing. If you go to the hospital, I mean, as an OB doctor, I did my fair share of tubal ligations. Mm-hmm. You go to the hospital and say, I want to pay cash for a tubal ligation. I don't even know what it would be now, but back then, and this was over 25 years ago, it would probably be about $12,000 to $20,000 for that procedure. How much is the doctor paid? $400.
Right.
How much am I in the surgery center? $400. the surgery center would have a fixed price. And if I sent my patient without insurance to the surgery center and say, give me a price on this procedure, it was $1,200. As a doctor who's only earning $400 that morning, where am I more likely to get paid? If my patient has had their pocket picked at HCA, or if they've come to the surgery center and they still have they got a payment plan that they can live with, and they can still pick up my meager fee and pay that as well. So it actually opens another option as far as how do you pay for the care. It's not as expensive if it's done in an outpatient surgery center. Hospitals will argue, well, we got to be ready for hell or high water, so we've got to have all of this overhead. Fine. Give hospitals a little bit of a break, and Congress does. The so-called DSH payments, disproportionate share hospital payments that go to hospitals, both for-profit and private hospitals, that's a big deal. The 1115 waiver, money that hospitals are funded from the federal government, that's a big deal, and it's a lot of money. So let us carve out a little piece and say, this is a physician-owned facility. We are going to run it very efficiently, but most of all, we answer to the patient.
So sitting back, because you are no longer in Congress right now as of January, and looking at all of your former colleagues, is there anything that's bipartisan that you think is going to actually pass to benefit patients and physicians in 2026? I thought PBM reform would have been on last December, and then the last minute tweet by Elon Musk killed that one. And I'm like, oh my God, we're back to PBMs, and people are getting PBM fatigue now. Where do you think the two parties align?
Well, there are a number of areas. I had a bipartisan bill that passed the House with no problem, got held up by special interests over on the Senate side. Stop me if you've heard this before. But it was the Preventive Health Savings Act. Mm-hmm. The Preventive Health Savings Act said, CBO is kind of tied to a 10-year window. So, think of it, the easy way to think about it right now is GLP-1s. You say, what about GLP-1s and control of prediabetes before a patient becomes a full-blown diabetic? Is there a cost savings there? Yeah, but there's an expense. If you're bound to a 10-year budgetary window, it's all cost. You can't afford it. Look at that cost. Mm-hmm. If you could look at 20 years or 30 years, there actually is a savings that will accrue in the out years. The example I used to give was proton pump inhibitors, Nexium, Prevacid. When I was in medical school, the number one treatment for a person with refractory peptic ulcer disease was surgery. It was a highly selective vagotomy and a partial gastrectomy. There were several listed on the surgery board every morning because it was a common procedure. A lot of people had peptic ulcer disease in the days before proton pump inhibitors. I remember really well the morning that Dr. Fortran from Baylor University Medical Center came down to Houston, where I was in medical school, and gave a symposium on this new medical treatment for ulcers that he had developed. It was called Tagamet. Many people are familiar with that older compound that used to be around. And then several variations and iterations later, we have the proton pump inhibitors. I remember Henry Waxman used to rail against Nexium in committee. This is a drug that's not necessary. These people are just making money. Well, guess what? If you prevent the peptic ulcer from ever happening, you don't have to have the surgery for refractory peptic ulcer disease. And as a consequence, there's a ton of money you're not spending. So if you just look at it as upfront cost, yeah, perhaps the company that put the market, the launch price of Nexium was too high when it first went out. We can have that argument, but that's what they thought the market would bear, and that's what they charge. Now you've got a generic. It's way cheaper, and you as a consequence, have a ton of people who are on proton pump inhibitors who never have to think, don't even know how to spell highly selective vagotomy and partial gastrectomy. I went down and talked to a group of surgery residents 5 or 6 years ago, and I said, show of hands, how many have ever seen a highly selective vagotomy and partial gastrectomy? They didn't even know what I was talking about. I might have well have been speaking Latin. They weren't familiar with it because it's not done anymore. It's not done anymore because preventive health care prevents the situation from happening. There are a ton of other examples where using this model of preventive health savings, allowing the Congressional Budget Office to have a longer window to take into account the savings and not just the upfront costs, we could have some phenomenal savings in healthcare. I was blocked by a very senior Republican in the Senate who said it was a budget gimmick. No, it wasn't. We passed it unanimously in the House of Representatives. I know those jokers in the Freedom Caucus didn't vote for a budget gimmick. They say they never will and never do. It had been well vetted, but we got held up in December. It was clobbered in the Senate. People have picked it up in this House. The momentum that was behind it last Congress, and that was the time to get it done. And look, it's exactly the same things that RFK Jr. is talking about now. He wants to make America healthy again. Well, part of that make America healthy is let's use all of the tools we have in preventive health care to keep people from getting sick in the first place. And he's right that diet and exercise and avoid red dye and don't eat M&Ms, all of that is important in making America healthy again. But let's also make available some treatments that we know will save money down the road and not let their cost prohibitive nature interfere with their being used right now. The greatest example I can think of is Sovaldi. When that was, hepatitis C was a disease that existed when I was a resident at Parkland Hospital in the 1970s. We didn't have a name for it. So we called it non-A, non-B hepatitis. Someone somewhere down the line said, hey, let's call it hepatitis C. So hence the name was born. But there was no treatment for hepatitis C. Once someone got it, they had it forever. And then somewhere along the line, someone figured out on Sovaldi, they figured out a way not just to treat hepatitis C, but to cure hepatitis. I mean, that was a big deal. Someone who had hepatitis C could now be cured. So Sovaldi was a watershed moment in the practice of medicine. Within my professional lifetime, we went from a disease that had no name that caused untold amounts of human misery, liver transplants, you name it. And now we had a way to not just treat the illness, but actually cure the disease. It was a big deal. It cost a lot of money. I think the launch price was somewhere between $60,000 and $80,000, and everybody threw up their hands. Of course, that was an expense that state Medicare plans had not been anticipating. So for all of the world, it looked like it was going to break the bank in the early days. But now, with more experience, and there have actually been other medications that have appeared on the market, the cost has come way down, and more people are being cured of hepatitis C than any other time in human history. And that just speaks, when people talk about, would you be a doctor all over again if you had the chance? The answer is sure. Because of the advances that are occurring, this next generation of doctors is going to have tools at their disposal to alleviate human suffering that no generation of doctors has ever known.
If we can get people and young kids to go to medical school. But you have so much enthusiasm and you have so much energy and ideas. Why did you not run for another term? Why did you walk away?
Well, you always want to leave when you're on top, right? And I was warned by my campaign manager, don't say you want to spend more time with your family. Everybody's going to figure you got caught in an affair. Don't say you're worried about your health, because then they're going to say you got bad poll numbers. But it's important to leave on top. And you mentioned it earlier, perhaps there is a little bit of a youth movement. That's not a bad thing. People, my generation, baby boomers, are moving on. They're passing away and passing the torch to a new generation of Americans, and that's appropriate in the United States.
You didn't want to be a Strom Thurmond or a Dianne Feinstein?
Well, don't get me talking, because at the end of their careers, they're pretty much useless.
I know. I was there when Strom Thurmond was there. I was there with Dianne Feinstein. So that's my maiden name. So people would always send me over to her office. And I said, if I was related to Dianne Feinstein, would I be working in this office? So it was always sort of a joke where I worked. I want to wrap this up because you're filled with ideas, and I would love to know, you only get one wish. I'm going to grant you a wish because I end every podcast this way. If you could create one change within the American healthcare system, what would that one change be?
Well, the one change would be activate the patient and let the patient be involved in their own medical decisions. So a health savings account, consumer-oriented healthcare, whatever you want want to call it, I would add to that physician-owned hospitals also add that dimension as well. I think that's where you're going to get some rationality, some market sensitivity back into, otherwise, look, if you just keep pumping federal dollars into subsidies, as Margaret Thatcher told us, sooner or later, you're going to run out of other people's money. Yeah. And then what's going to happen? Mm-hmm. And there was an argument with the Affordable Care Act, and it continues to this day, that they are making things so bad, they are wishing for the collapse of the system, and then they get Medicare for all. But Medicare for all is just Medicare Advantage writ large to everyone in the population. Be careful what you wish for, because Medicare for all, are the insurance companies suddenly going to say, well, we're just out of the health insurance business altogether? No, they're going to be the ones with the expertise. They're going to be the third-party administrators in this new federal system. Kamala Harris had to back away. She co-sponsored Bernie Sanders' Medicare for all bill. She had to back away from it when someone exposed the fact that 180 million people in this country get their insurance in the ERISA market through employer-sponsored health insurance. One of the first lines in the Medicare for All bill that Bernie Sanders had out there that Kamala Harris co-sponsored was that we do away with all private health insurance. You would no longer be able to get employer-sponsored health insurance. Everyone gets shoved into this one bucket. Medicare Advantage goes away as well. I don't call it Medicare for all. I call it Medicaid for all.
Well, that's what it would be, right? It would be Medicaid for all.
And you know what the problem there is. Mm-hmm. As a doctor, I did Medicaid deliveries because it was my calling. It was what I was supposed to do. But I also knew this. I couldn't just say I am opening my practice to all Medicaid comers, because I would be swamped and I wouldn't be able to pay the bills. Running a North Dallas practice, I wouldn't be able to pay for my help, to pay my light bill, because the electricity company is not going to say, oh, doc, we understand you're doing a lot of Medicaid, so we're going to cut you a break on your electricity bill. That doesn't happen. The building owner is not going to say, we know you're a good person, so we're going to cut you a break on your rent. No, that does not happen. All of my costs would continue, but all of my accounts receivable would suddenly plummet to Medicaid levels. I was out of business. I couldn't afford it. But I want to share something with you. When you talk about enthusiasm and looking toward the future, there is a physician-owned hospital in McAllen, Texas, called Doctors Hospital Renaissance. I encourage people to look them up on the internet. They run their OB practice almost 80% Medicaid. Their employees are happy. Their doctors are happy. Most importantly, their patients are happy. They are able to make it at Medicaid rates because they have the flexibility of a physician-owned hospital. In fact, during COVID, they were one of the few places in the Rio Grande Valley that had a COVID unit opened up. COVID in the Rio Grande Valley was particularly hard because everybody goes to Mama's house for dinner on Sunday, and they all mingled and came home with COVID, and they all came down with it. Plus, you have a population with high propensity for diabetes, and perhaps they may be a little bit above the ideal weight. So they were a population who was truly at risk for COVID. Doctors Hospital Renaissance opened up a COVID unit that was one of the standout units in the, not just in the state, but in the country. But then here's the thing. I had to go to bat for them and get a waiver so that Medicare didn't close them down because they expanded a physician-owned hospital service. That's how crazy the system is right now.
Well, you'll love this. You will love this. In 1974, I was born at Doctors Hospital in South Florida. So yes, pre-Stark and pre all of these regulations, and that doesn't exist anymore. So I think what you say definitely resonates, and having doctors be able to be more vested and having patients be able to, or require patients to be more vested in their healthcare. Dr. Michael Burgess, thank you so much for joining me on Working Healthcare. If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going in between episodes. If you've got a question, an episode idea, or someone you think I should feature, send me a note at meredithhirsch.com. Thank you all for the 5-star reviews. They help more listeners find the show. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare, because you can't fix what you don't understand.